Good evening, ladies and gentlemen, and thank you for taking out time to join us for today's talk. We'll be speaking a bit on audience. Speaker for tonight is Dr. David. I think most of you already know him. He doesn't need a very long introduction. He has been a senior nephrologist in SSRNH for almost a decade now. And prior to that, he worked for people and communities in the UK, in Scotland, and has been working as a consultant nephrologist in college. So, Dr. David, of course. Thank you.
And of course, the Renal Association welcomes all the members of the Cardiovascular Society. Thank you for coming. So, the topic of the talk today is ARNI and the kidney. I don't know about you cardiologists, but as nephrologists, we've had loads of SGLT2 inhibitors talk for many months, and whether it's in the flesh or as webinars. And to the point that even the other day I was watching one and my wife said, oh, this is a new drug for diabetes. Actually, it's better for other things like the kidneys and the heart. So I thought we should stop talking about SGLT2 inhibitor and talk about a drug. But I must confess, as nephrologists, we haven't paid a lot of attention. So ARNI. And ARNI, of course, made me think of Arnold Schwarzenegger and his films. And so will we see, after so many years of the introduction of ARNI, and compared to the SGLT2, it seems to be ages ago that sacubitril valsartan was introduced. I still remember the launch here in Mauritius, I think it was in Hilton. So much has passed, and we haven't really talk about it in terms of the kidney. It's just been the cardiac effects. So is there some blast action coming from this drug? I'm also aware that I'm talking about a drug that I've never used. A drug that is for cardiologists. A drug that I'm a bit scared to use. And I'm going to I'm talking in front of an audience of cardiologists, more cardiologists than nephrologists, and maybe I'll get terminated by the end of this topic because really we're going outside our usual comfort zone. So first, there's a few slides on heart failure, but more for the nephrologist in the audience than the cardiologist. So heart failure is defined as a clinical syndrome characterized by typical symptoms: breathlessness, ankle swelling, fatigue, accompanied by various signs, elevated JVP. Nephrologists love looking at JVP, pulmonary crackles, peripheral edema, and it's caused by some structural, functional cardiac abnormality, and so on. And there are several types of cardiac failure. And we can see a difference between nephrologists and cardiologists. We like kind of short acronyms like AKI and CKD, whereas cardiologists go for more complicated acronyms, so HFrEF, HFpEF, and there's a new one, FBREF, and then that's on top of STEMI and so on. But the main criteria for separation is the ejection fraction. So if it's above 50% is considered to be preserved ejection fraction, and with lower is reduced ejection fraction, and with mid-range ejection fraction somewhere in between. So there's a pathophysiology of reduced ejection fraction heart failure, which starts with damage to the cardiac myocytes, which lead to change in size and shape and function of the heart, which leads to systemic neurohormonal activation and a number of other things, and including maladaptive remodeling. And we will see the same phenomenon in the kidney. And that leads to both symptoms and morbidity and mortality. And the heart failure is a progressive disease with chronic decline, but also with acute episodes. And I could relabel this graph and put CKD, the same thing we see with CKD, with acute exacerbation, until we reach endgame mortality. So this slide says that heart failure symptoms severely impact quality of life, but may not be recognized. I'm surprised. I think it is a very, very clinical entity with a lot of impact on patients. And so we need new treatment for these patients. And it carries very serious prognosis, so increased mortality, 6 times all-cause mortality. In patients with symptoms that require heart failure hospitalization, and times 5 all-cause mortality in patients worsening heart failure symptoms. And HFrEF is characterized by frequent hospitalization, so it's not only mortality but morbidity. And 50% of heart failure deaths occur suddenly. And I think cancer carries such an emotional element to it, and we talk a lot about cancer, and we focus on its mortality, and we forget that many non-communicable diseases have equivalent or higher mortality, and it is the case of heart failure. And I will show a similar graph for chronic kidney disease. Right, now when you feel a bit more comfortable, kidney disease. So this is CKD classification. And you can see in the front, just love figures and complicated tables, so sorry for that. So I think most of you should know, but in case you don't, then we classify CKD according to renal function, measured by eGFR, which is calculated from serum creatinine through an equation. The one we use at present is the CKD-EPI from 2009. And inputting the creatinine and the age and the sex of the patient, we get a number, the eGFR, which is roughly 100 for normal patient in good health. And we can classify in various stages. So we've got G1, 2, 3A, 3B, 4, and 5, as we can see in the chart. And then the second dimension is a measure of kidney damage, which is albuminuria. And now we are meant to do it through an albumin-creatinine ratio, which is a spot sample in the morning, except it's very difficult to get results in a hospital, especially at SSRN. We kept sending samples and the results will come back. But you can classify in 3 stages, and the importance of it is albuminuria is linked to increased mortality, especially over cardiovascular side, and also progression of kidney disease. And this is our cancer versus CKD chart, and you can see that dialysis is the orange line, so it's pretty poor. So this is 10-year survival probability, so it's about a mortality of 70% at 10 years, and numerical for the cardiac disease, it was, for 5 years, it was about 35%. So very similar. This is a slide I've been using for a long time, since I was in the UK. And on the left is the study by Go et al. They took more than 1 million patients, they measured the creatinine and eGFR and followed them over a number of years and calculated the rate of death. And you can see that when the renal function goes below 45 mils per minute of eGFR, there's a sudden rise in rate of death. And that's why stage 3 was split into 3A and 3B, because looking back, it's very awkward to have a 1, 2, 3A, 3B, 4, and 5. And on the right is a old study from 2004, various stages of CKD, and the RRT is going on dialysis or transplantation, and then the rate of death. And you can see at all stages, you're much more likely to die than to go on dialysis. And even stage 4, you almost have a half the chance of dying over 5 years compared to 20% chance of going on dialysis. But these are all figures. And this is the era where ACE inhibition and ARB was just only starting. And actually there has been a change in the figures. It's less, the difference is less stark, so people die less, but there's still a very significant risk of dying. This paper from 2018 is very interesting. It's a major consortium of researchers from many countries, 29 cohorts of patients with stage 4 CKD, and basically we collected 264,000 patients, and they measured lots of parameters, especially the risk of dying with cardiovascular disease and going on dialysis, and they did mathematical modeling to try to predict risk of death when on dialysis. And you can go on the internet, so it's ckdpcrisp.org, and there's a lot of other equations, but you can input these various parameters and see what's going to happen to your patient. So I've done a little calculation for eGFR of 30, and on the very top line is categories of sex and age, so male 30, male 40, and so on, and then we have female on the right-hand side of the panel. And the creatinine that would give an eGFR of 30. And we can see that there's a wide range of creatinine that give 30, and that in the elderly, relatively modest creatinines, 142 in ladies, at the age of 80 will give an eGFR of 30. And then as we go down, we have 3 layers of albumin creatinine ratio, starting with a relatively low one at 3.4, and then it's 33.9, and then 84.8. And the striking thing is that if you look at young patients, it's clear that they have much higher risk of going on dialysis. That's been computed for the 2 years risk for the next 2 years. But as we go along the older people, so 60 and 80, and which is the majority of the patients we see in hospital, you can see the rate of cardiovascular disease increases and the rate of death. And we look at the people at 80, they are far more likely to have a cardiovascular event, stroke or MI, or die than on dialysis. So in some ways, it's good in Mauritius, unless in hospital, we don't use eGFR 30 for referrals, because we'll be looking after loads of patients that have a very high risk of dying of cardiovascular disease, but relatively low risk of going on dialysis. And really, we need a multidisciplinary team to look after these patients, because it's not a uniquely dialysis issue. Now I'll just move to acute kidney injury, which we haven't had a talk on acute kidney injury in Mauritius. Acute kidney injury is our version of MI, and it's sudden reduction in renal function, and these are the definition. So stage 1, 2, and 3, increase in severity, and on this column it's based on serum creatinine going so many times above baseline, so it gets worse as we go down. Of course, if you go on dialysis because of your so unwell, then it's definitely stage 3, and then there are the urine output parameters. And surprise, surprise, as you go down the stages, the risk of dying increases. It's very difficult to have very clear figures for AKI because it depends on the population. There's been a lot different in different countries. So this is a UK figures. They think that overall in the country for people admitted into hospital, the mortality is 33.6. And there are many patients who get AKI in the community but do not get admitted. And within the hospital population, there is a difference between the elderly patient coming with dehydration or a minor sepsis And we have patients who are having the cardiorenal syndrome, or the patients who go to ICU, multi-organ failure, and these people have a mortality rate of 70%. And then there are also the post-operative patient with very high mortality. This is an interesting study from Canada from a couple of years ago. They looked at it's a population-based cohort study from Ontario, 156,000 survivors of AKI. So they've already lost a number of people there. These are the survivors. And they look at their mortality rate in the following years and for various conditions. And the top two is cardiovascular and cancer. I would have put it cardiovascular, but cancer rate was very high, some of it due to chemotherapy or obstruction of the immune tract. But 40% of the cases had de novo cancer. So this is something a bit new, which I didn't know before preparing for this talk. But it's clear that AKI doesn't stop at the moment the patient recovers. So we now think of AKI, AKD, and CKD as interlinked. So AKI is something that happens suddenly, it's less than 7 days. If it persists, then it becomes acute kidney disease. And if it's beyond 3 months, it's chronic kidney disease. And so we have people who are in good health, some of them become at risk, they still have normal function, they start suffering damage, and the start of a decline, decreased GFR, they go into various stages of kidney failure, and finally death. And at all stages, they can get complications, including death. Okay, this chart, I think the main thing to remember from this is the course can be very complex and different from patient to patient. You can recover quickly, or you can have subacute AKI. But if we follow this patient over many years, we'll see a good proportion of them will develop chronic kidney disease. And why do they develop chronic kidney disease is because the repair process goes wrong, and includes a lot of inflammation, fibrosis, and so on. Let's talk of senescence of various cells, and this is where the SGLT inhibitors may help, because they may arrest this cycle of senescence and also act on the energetics in the kidney. And the truth is, for AKI, we're still at the very beginning of getting to the bottom of the problem. We're still in the process of understanding how frequent it is. So in other countries, they have electronic alert system, but the computer system will tell you this patient with AKI. In Russia, we're still having bits of paper that takes weeks to come to us. So we have absolutely no chance. And we haven't had any impact on the mortality of AKI, partly because more and more people get AKI. There are new ways of getting AKI. For example, in oncology, there are so many new drugs they're giving that causes AKI. And so we looked with envy to our cardiologist colleague. For example, for MI, there's a study from Denmark which shows the mortality of MI. This is the whole period. This is from 80s, 90s, and 2000. And you can see that the community mortality keeps decreasing. There's been vast advance in survival in myocardial infarct. To the point that people don't know that, but acute kidney injury is a lot more deadly. I think this figure has shocked me, maybe it's a bit exaggerated, but I think the general idea is there. AKI is more deadly than acute myocardial infarct. And it's a whole talk discussing why we're not progressing with AKI, and this is maybe we're not progressing in terms of tests and biomarkers. I've been 20 years, I've been to meetings, we're talking about new markers for AKI and GAL and so on, but nothing has come to fruition yet. So now let's talk about the cardiorenal syndromes. Well, not this kind of cardiorenal syndrome, which unfortunately do have in the hospital, where we have some divergence in views about the clinical state of a patient. Cardiorenal syndrome was actually discussed in a talk in 1920-ish in London, but the first mention in the publication was in 1951 in the French journal L'Avenir Médical. And you can see, this is from the PubMed, the number mentioned in the literature. There's nothing much. There's an isolated paper from Saudi Arabia, I think 1988, so somewhere here. And you made observation that many of the patients with renal problem had a cardiac problem and vice versa. But really things started to change in the new millennium. And you can see from 2011 there's been quite a lot of publication. And before the concept of cardiorenal, we already knew that there was a common pathway for the failure of many organs, whether it's the heart, brain, retina, peripheral vessel, or kidney. I think you're familiar with this kind of slide. As far as heart failure is concerned, there was an interesting paper in 1993 by Milton Packer, and you might recognize his name. He's still very active. He's given a few talks recently on the Emperor trials, so EMPA refers it in heart failure. And there he is speculating on the various models of heart failure. So from the 40s to the 60s was viewed as an endometrious disorder, and therefore there was a cardiorenal problem, and could be treated with diuretics and digitalis. In the 70s and the 80s, then it was viewed more than hemodynamic disorder, and then there was a trial of inotropic agent, and these are damages. As we know, these were not terribly successful. And after the 90s, we go into the neurohormonal concept, and we went into the era of ACE inhibitors and beta blockers with much greater success. So classification of a cardiorenal syndrome, general definition, a pathophysiological disorder of the heart and kidneys, whereby acute or chronic dysfunction in one organ induces acute or chronic dysfunction in the other organ. So type 1 is acute cardiorenal, so the heart is the first organ to be affected, and that leads to acute kidney injury. So it is a sudden event, acute decompensation, ischemic coronary angiography, the contrast, cardiac surgery, and there are many ways that can do, but basically if there's decreased cardiac output, obviously there is decreased perfusion of the kidney, and also there's increased venous pressure. And this concept of venous pressure is very important, because if the venous pressure is very high, that makes filtration a lot more difficult for the kidney. And something that I've not actually appreciated until very recently. And it's this increased pressure in the abdomen can lead to, of course, to the heart, but also to non-cardiac causes like enthusiastic IV fluids, especially in the context of someone going into sepsis or someone who has had intra-abdominal surgery or trauma, the accumulation of a lot of fluid, and all that leads to an abdominal compartment syndrome. So I'm just straying a little bit from cardiorenal. And the Americans are very keen in measuring the abdominal, intra-abdominal pressure as a guide to predict acute renal injury. Of course, there are other ways that the heart can lead to kidney injury, so from the exogenous factors, contrast, ACE inhibitors, diuretics. There could be humoral-mediated damage, hormonal factors, and immune-mediated damage. And then type 2 is still the heart causing kidney grief, but in a chronic fashion, and that could be through various mechanisms: anemia, genetic risk factors, low cardiac output, hyperperfusion, and so on. And then type 3 is the kidney that's causing problems, so we're talking about acute kidney injury. And of course there is fluid retention that causes a lot of stress on the heart. There's hypertension, sympathetic activation, vasoconstriction with activation of the renal angiotensin system. Of course, a lot of electrolyte, acid-base abnormalities, and also again immunological mechanism. Finally, type 4 is the chronic renal cardiac, so various stages of chronic kidney disease, And so there are shared risk factors for both diseases, but also the presence of anemia in kidney disease, the presence of uric toxin, and very importantly, the whole derangement of bone metabolism axis, high parathyroid hormone, deposition of calcium in all the blood vessels, so we get very rigid vessels. And it is clear that cardiac disease in CKD is not the same cardiac disease in other people. And we know that a lot of the conventional treatment for non-CKD patients for the heart do not work for the kidneys, and this has led to some degree of nihilism. Finally, type 5 is when you have a non-heart and non-kidney issue that's causing damage to both, so for example sepsis, and there are many ways that it can happen with the following risk factors. Right, so we've learned about heart disease, kidney disease, cardiorenal syndrome, but what does it actually mean in the immersion context? Because we always need to look at what's happening here. First warning, of course, with any data, there could be some quirks, and they don't always tell the truth. So this is the rate of death from various diabetes and circulatory disease, and the introduction of ICD-10 coding produced a major change. So everything needs to take with a pinch of salt. And this is the mortality to the main non-communicable disease. And number one is diabetes, about 2,000 for most years. Heart disease is not far behind, 2,000. And quite a lot for cerebrovascular disease and cardiovascular disease. And for kidney failure, 187 deaths in 2006 and 50 in 2018, only 50. There's something wrong here. I think anybody who is in contact with dialysis patients will know that a single hospital will have more than 50 deaths from dialysis in a year, a lot more. These are the principal causes of general hospital discharges, and so it's nice to see that children involved, so that's quite a lot. Let's look for heart, 4,192, gastritis is a lot, so hypertension, so all these in the several thousands, and we need to go to the bottom to see colic, which is still not very nephrology. We need to go even further down, renal failure, 453 discharges from a hospital, all 5 hospitals in Mauritius in a year. I think, so there's several issues, and maybe us nephrologists, we need to be looking at how the notes are coded, because it's giving a distorted picture. Well, look at this graph. So it's very incompatible with the figures we've just seen. These are the number of dialysis patients we've had from 2000 and 2020. And it's more or less a steady increase of about 50 a year. And this figure is from last month, so it's still 6 weeks ago. We need to depend on foreigners to calculate for us. So we have a major study from the Global Burden of Disease group, which done it before, and in February of this year they published a paper in the Lancet, and they looked at the epidemiology of diabetes, hypertension, cardiovascular disease in all the countries, and through complicated mathematics and equation and so on, calculate the risk of kidney disease. And we can see that red is very bad, and of course we are one of the reddest countries in the world. And this is actually for the disabled adjusted life years per population, so that gives an idea of how many years are lost to ill health and disease and death. And Mauritius is third highest in the world, with the Marshall Islands and El Salvador doing worse than us. And this is for prevalence. Here, we've got apparently 218,000 people with chronic kidney disease, which for a age standardized rate is about 13.7%. In terms of the population, we've got an adjustment, it's about 17%. And the rate of increase since 1990 is 19%. And then we estimate the rate of the death rate at 1,070. And for both, we are second highest in the world. When I first saw it, I said, this is too much, 1,070 is no way. And then if you look closely at what's figures from our patient analysis, and you realize, maybe this is a realistic figure, or maybe it's still an underestimation. So tabulated, a striking thing here is that so many small island nations are top, and these are the same nations that have diabetes, of course. And it's taken quite a few months to be reported in the local press. And it should be #1 feature. Now, can I convince that these figures are true from the Lancet, or is it just made up? This USRDS is a registry system from the States for dialysis patients. So they look at various countries, the rate of people on dialysis. So basically at a certain point of the year, they count everybody on dialysis and transplant, and these are the countries. Taiwan is very high up there. And calculation, correct, it's 2018, updated for 2018, so 1,295 per million population, so we're somewhere here, the level of France, about 12 or 13. If you look at new patients every year, Taiwan is top. I exclude Jalisco because it is a province of Mexico. Another province of Mexico. We don't have total Mexico. So as a country, I'm not very sure where Mexico is, but Taiwan is #1 at 523, and Mauritius about 538 new patients going on dialysis every year. And for the last 4 years, we've been top at least 3 out of 4 years. The other thing that I found very interesting in the 2018 health statistics is the degree of cesarean section, which is increasing relentlessly. So that in the public sector or the private sector, 46 to 59 there, 31 to 49. And the other thing that's striking is the percentage of low birth rate, so less than 2.5 kilos, 15% in 2003 and 19.3 in 2018. Slightly different in the private health sector, but the general trend is still going up, 8.6 to 11.1. I was thinking that in Mauritius, we're getting more developed, that these things should be improving. And this is in graphical form. That's for Mauritius. That's for Rodrigo. It's doing much better than us. Why is low birth weight very important? And of course, unfortunately, my colleagues from Renal Association, I always show this slide in my talks. So this is Barker, the Englishman in the 80s. He had this amazing idea to look at the birth weight of a population coming in Shropshire in England and compare people with MI and without MI. In fact, people with MI had low birth weight. Sorry, Shropshire's Hertfordshire, sorry. And basically the same phenomenon can be found for kidneys as well. So you have low birth weight, you have more kidney disease, and we know now because you're born with less nephrons. And basically now I think many of you are aware of the developmental theory of metabolic disease. If you have a difficult time during pregnancy as a fetus, for whatever reason, you are born with inadequate building blocks and adaptation to a situation of starvation, and the manifestation for different parts of the body is different. So here it's kidney disease. So here you get metabolic disturbance, increased risk of diabetes, and so on. So basically bad news. So we can see from these figures, we can predict that heart disease and kidney disease will keep on increasing. But even before considering other things like the population structure, Mauritius, lifestyle, diabetes, and so on. This is still from the health report. I know they do not help themselves because here it's stretched, whereas here we've got a 10 years gap. But we can see that life expectancy is not improving as quickly as it used to be. And the big question, is it going to start falling? Right, I think the Novartis guy will be happy now to finally reach the point that I talk about ARNI. So we're talking about the natriuretic peptides that are released by the heart, and this happens when it is under pressure, when the atrial wall is stretched, and that leads to a number of things. Basically there's a dilation, and the kidney is forced to have neprilysis. There's increasing the dilation here. But there's something called neprilysin that degrades natriuretic peptides and other substrates. And therefore, the level of these natriuretic peptides is limited by neprilysin. So if you could have more of these peptides by inhibiting neprilysin, then maybe we'll have an effect on heart failure. And so basically that's the idea of sacubitril valsartan, which inhibits neprilysin, so it acts on the naturopeptide system and also on the angiotensin system. And that leads to, in general, a decreased vascular tone, decreased blood pressure, decreased sympathetic activity, and there's less of this. One important thing is that neprilysin also blocks the breakdown of bradykinin, and ACE inhibitors also do that, so they increase levels of bradykinin. So the combination of ACE inhibitors and neprilysin inhibitors is not good because of increased risk of angioedema. So that's why sacubitril has to be paired with valsartan. If we have valsartan on its own, there's insufficient blockade of the angiotensin system, and basically there's still possibility of conversion of angiotensin to angiotensin 2. So that's why we have ARNI. So it's both an angiotensin receptor blocker and neprilysin inhibitor. So this is the molecule of sacubitril. So I think I've explained that. I'll skip this cardiology bit. There's no way of animation. So simultaneous inhibition of neprilysin and suppression of the renin-angiotensin system has complementary effect. I think we mentioned that. Vasodilation, decreased vasoconstriction, and more importantly, it decreases NT-proBNP, which is a marker of cardiac wall stress. BNP is always measured, but there is normally, in people not on sacubitril valsartan, both are increased in heart failure. But with this drug, there's dissociation between the two. We have a decrease in the NT-proBNP, but the BNP levels remain high. So, clinical trials. So another moan from a nephrologist. We get a bit annoyed because so many trials, including the latest one on COVID, they just systematically exclude kidney patients. Anybody with EGFR less than 30 is out. And we've shown that a lot of people have a chronic kidney disease. And there is this term, renalism, where we forget about kidney disease patients. Some of the cardiology colleagues might think it's realism not to be bothered with these kidney patients because they have such high mortality anyway. There's no point in treating them. So it's the same. Most of the trials I'm going to show you, there's no data for EGFR less than 30. So the first trial was Paramount, which came in 2012, and basically this double randomized control trial was basically looking whether giving this drug to people with a preserved ejection fraction lead to a change of the NT-proBNP, which is the primary endpoint, and this it demonstrated quite clearly. And then the big clinical trial with the clinical outcome was the Paradigm HF in 2014. So these slides came from Novartis. I don't know why they put exclusion on both sides. It's inclusion, of course, on this side. So people with reduced ejection fraction, high BNP and NT-proBNP, and stable, and on this side excluded, of course, the renal patient, hypertension, acute patients. The important thing about this trial is that they were comparing sac-val against enalapril, which to me doesn't look logical. It would be nice, against valsartan. So there's a lot of argument and there's a lot of criticism for this trial for this particular reason. The other thing important about this trial is that there's a long running, that they chose a patient who were very stable, and does that reflect clinical practice? And basically for the cardiac parameters, there was a very significant improvement, so 20% relative risk of the primary endpoint, which is death from cardiovascular causes and first hospitalization for heart failure. And then mortality, 20%. Anyway, it's all good news. And then the initial analysis for the renal function was not that significant, but you can see that the sacubitril valsartan did a bit better in terms of slope than the enalapril group. So at least it's not dangerous to the kidney, which was a big concern to nephrologists. And this is again a funny graph, but actually the difference is less than it appears, only 2.2 to 2.6. So on the left is sacubitril valsartan, on the right is enalapril, and it's the decline in renal function. So it's actually a little bit better in the drug, but not significant. And then we look at various adverse events, and there was no significant difference. I'm going to skip that because. And then Paramount comes back with a further analysis, and they basically look at estimated glomerular filtration rate. So we're now in 2014. So we've got sacubitril valsartan up there and valsartan below. So that is a nice trial. Valsartan versus valsartan, and he's just managed to get significant at 36 weeks if you look at the change from baseline, the adjusted p-value of 0.025. And then Paradigm comes back with an analysis, and we're looking at patients who are already on the inhibitors of the renin-angiotensin system, and people with heart failure particularly. And we've got people with no diabetes and diabetes, and obviously diabetes have a higher rate of progression. And then we've looked at adding sacubitril. So the first line here, the dark one, is no diabetes with enalapril, and the pale line is no diabetes with sacubitril. As you can see, we're doing a little bit better. And then the red line, that's diabetes with enalapril, and this one with sacubitril. So a little improvement in both cases. So that's paradigm 2 coming back. This paper that came in 2018 also looked at the renal effects of angiotensin neprilysin inhibition. And it's still paradigm, so it's actually paradigm 3, so it's a third comeback. It's like the Terminator, we keep reanalyzing the data. And basically the initial data did not show any improvement here, partly because they had this funny criteria where there had to be more than 30% of mils per minute of GFR to 60, which normally we don't use, and in this category sacubitril didn't do well. So they basically just removed it and had the 50% decrease in GFR, which is a more conventional criteria, with end-stage renal failure, and magic, they managed to get some significance and say, yes, the drug is helpful to the kidney. And this is the graphical representation of that. So it's a bit better. The worrying thing that was noted in earlier trials is, however, that with sacubitril valsartan, you do not have a decrease in albuminuria, whereas you do with enalapril. So we know that how nephrologists are obsessed with albuminuria, decreased albuminuria, with decreased progression to kidney disease and rate of heart disease. And there's been a lot of talk where is it significant or not, and I'm not going to tell you or involved in these hemodynamics, but basically people with heart failure state, there's so little pressure gradient across the glomerulus, they cannot filter enough. And with an ACE inhibitor that goes in vasodilation, they can maintain a positive filtration pressure throughout the length of capillaries. And with sacubitril, it actually goes after vasodilation and increases the pressure in the kidney. Many nephrologists are a bit worried about that because we have increased transmissional pressure in the kidney. Sure, is not good. So a big question mark. UK Heart 3 is different. This is a trial done by the nephrologists looking at patients with chronic kidney disease. So they've looked at people above 18 with a GFR between 30 and 60 with a albumin creatinine rate of about 20, or a second criteria between GFR of 20 and 45, we got this of albumin creatinine ratio. And they had a good spread of the various stages of CKD and ICR and various types of kidney disease, including diabetic kidney disease. And basically, they didn't show a big, there was no benefit of the drug in patients with CKD in terms of eGFR. But they did see in terms of potassium, there was a little increase in potassium, but it was not significant. And they did see that the albumin creatinine ratio was actually, in this case, they found a decrease as opposed to the cardiology trials. Blood pressure was decreased, and was decreased in the pro-BNP. So the conclusion was, yes, we can use sacubitril in CKD patients, but there was no benefit to the kidney. Fortunately, didn't look at cardiac outcomes, which of course are very important as well. Right, I'm going to take a little pause. I invite you to take your mobile phone and go on www.sli.do. You do that, please. I need to disable it. So if you go there and put the number 91380. Okay. There you go. Women, but they influence around the whole. Okay, little poll. I just would like to know, just for cardiologists, how many of you have used this drug? Huh? Okay, I think we have 30 people, 14 people voting, and let's see the result. Why is it not showing? Okay, so we have 57% of respondents saying occasionally when indicated, 21% once or twice, 14% would like to, but didn't have a chance. And there was somebody whose routine practice using sacubitril. Well done. Now, for non-cardiologists now. Okay, so I think everybody does believe in sacubitril, but 30% believe it's up to the cardiologist, and 30% would like to, they didn't have a chance, and there's a few that have used it a few times. Well done. Now, I would like to talk about a patient that I've seen recently in private practice, first presented in around July with terrible fluid overload, heart failure, high blood pressure, and detecting of 200-ish, and she has diabetes, but also a very long history of hypertension. And it was a question of juggling various drugs and giving diuretics. And she eventually improved, and then she was readmitted with the same thing, and then she got better, with the creatinine going up and down, and finally she was readmitted 2 or 3 weeks ago. And at this time she was bradycardic with a potassium of 6.2, cutting up to 50, with edema. The legs were swollen, and of course she got diuretics, and she was given drugs to speed up her heart, and then she went into fast AF, and the cardiology diagnosis was of tachycardia syndrome, and it was a plan to put a temporary pacing wire and then a permanent pacemaker. But in the meantime, she was very food overloaded, and we tried to give diuretics, and then she would pass a lot of urine, and then the urine would just urine would go down, and then you have to rehydrate, and then she went to fluid overload again, and the creatinine was going up and down, up and down. And throughout, the blood pressure was very tricky. It was quite high. She was on calcium channel blocker. She was on methyl dopa. We couldn't give beta blockers because of the bradycardia. She didn't have a pacemaker yet. I think eventually my cardiology colleague did give a small dose of beta blocker. I think she was on nitrate as well. So I just wonder, what do you think would you add to this patient who the potassium had gone down by about 3.2? So what would you give the patient to help? Still hypertensive, urine output okay-ish, potassium low, but blood pressure very high, and always on the verge of going into decompensated heart failure. Right, a few people have not voted, but only 16. Right. I think my job is done because most people have chosen sacubitril valsartan, 43%. 10% chose SGLT2, hospital on 9%. Hydrazine 17%, ACE 20%, and in mineral receptor antagonist at 4%. Actually, I gave the patient some epteridone, and she, I don't know whether it's coincidence, maybe she was improving anyway. She did improve. But still, she always looked so frail and on the verge of still going on heart failure at any point. The potassium didn't go up. She still had a touch of lymphedema. The creatinine was coming down. I was thinking, when she goes home, what do we do? Do we need to do something else? Basically, here, I don't know the answer. There's no right or wrong, but I'm just curious what you would do. So she's already on the MRA. She's already on miain, she's already on the calcium channel blocker, she's already on Lasix, she's no longer on nitrates. What would you do? People are more shy this time to decide. Okay, 2/3 would go for sacubitril, and then 1, I think, for ACE inhibitor, 2 for hydrazine, surprise, and 40% went for SGLT2 inhibitor. I gave a patient a SGLT2 inhibitor because I was too scared of sacubitril. Maybe I would do differently this time, having prepared all these slides. Anyway, I don't know what happened. She went home, so I'll tell you the rest of the story another day. Now, final question. Last week I went to 05. I didn't tell the CIC there, Dr. Siran, but I went through all the notes I could see of all the cardiac patients, and I recorded the age, whether they had diabetes or not, and their creatinine. So what do you think is the percentage of patients who have CKD in a cardiac ward in the regional hospital in Mauritius? We already have a few people who do not care. Right, it's a close race between 52% and 65%. Okay, we'll just stop here. So I think 52% is the consensus. So we go back to here. I need to share the screen, but I can't share it because oh, well. Okay, good. Okay, so I've got a total of 25 patients. So diabetes like orange and non-diabetic blue. And it's quite striking that we have 4 out of 25, 16% of patients are proper renal patients with dialysis or transplant. But look at that, so many patients with 3A, 3B, and 4. Basically, only 16 patients do not have chronic kidney disease in the cardiac ward. I'm talking about giving SGLT2 in patients with just recovering from acute decompensated failure. That's something I'm going to on the background because this paper just came a few days ago. Sotagliflozin given in people with diabetes and recent worsening heart failure, so we put on it before discharge, and it was very striking within 18 non-stable and marked separation, hazard ratio of 0.67, and p-value less 0.01. So dapagliflozin is remarkable for also having more SGLT1 activity, and I think that's going to be the downfall of this drug, because one problem with this trial, there's actually 2 papers in the New England coming in the last 3 days, and there's been a lot of GI side effects with this drug. Okay, more clinical trials. We know that lower pro-BNP is related to less cardiovascular events, so there was this trial, the Pioneer HF, that looked, again, comparing sacubitril valsartan with neprilysin, but in the context of acute decompensated heart failure. So very different from paradigm where we were looking at stable patient and basically at the proportional change. So it did reduce it, but what does it mean in terms of cardiovascular outcome? I don't think they looked at it, but in terms of worsening of renal function, there wasn't a particular problem, and hyperkalemia was slightly increased. sorry, I'm wrong. There was a composite of death, rehospitalization, and so on, and sacubitril wins. Now, more recently is a Paragon trial, so I'm going to go a bit faster, but this is August 2020, so we look at people with preserved ejection fraction, and they look at the renal composite outcome of either a greater 50% in reduction in eGFR relative to baseline, attainment of end-stage renal failure, or death due to renal causes. And you can see a nice separation of graphs with a hazard ratio of 0.5. And the eGFR slope also looks good. So we can actually have more emphatic results for protection of the kidneys in patients with preserved ejection fraction rather than reduced ejection fraction. I'm not very sure why. Right, bits and pieces. We've got two meta-analysis. We've looked at various things. They've looked at, oh, I can't remember now. Basically, they've looked at proteinuria, renal function, eGFR, and so on. And the consensus was there was a slight benefit of sacubitril valsartan, and also they didn't see that there was a huge problem with hyperkalemia, but hypertension was a bigger problem. The second meta-analysis, I think, is more clear on the renal outcomes. So on the left, it's good for sacubitril valsartan, and some of these trials are quite small, but if you look at the big ones, Paradigm, Paragon, there's a clear paramount. Pioneer is acute decompensated heart failure, and the length of follow-up was relatively short. And then finally, patients on dialysis, there's been a few papers looking at it. They've looked at various cardiac markers, but we do not have any outcome figures. The numbers are small, we can't make a conclusion. But what is clear is whether it's peritoneal dialysis or hemodialysis, sacubitril valsartan is safe. Now, this is the GACC heart failure journal just from a few days. So it seems suddenly this year, after a long delay, there's a lot of data coming on ARNIs, and there is another Paragon, so reanalysis. We have a quick look at that, and then talk about another cardiac biomarker, which is CORIN, which responsible for conversion of the precursor to the BMPs and so on. And basically, Paragon HF shows that there is benefit of sacubitril, even patients are already taking an MRA. Most of them are spironolactone, not eplerenone. And so if you look at the graph on the right-hand side, so the dark line is sacubitril and MRA. That's the best group if you compare with sacubitril and no MRA. We didn't talk about it, just found it strange, but if you look at the people on valsartan only, if they are on MRA and valsartan, they do worse than without MRA. So that's a bit strange. So is that a real effect or not? Is there some kind of synergistic effect between MRA and sacubitril? So what does it mean? Well, I think whoever imports production binders might make some money, because all these drugs we want to give, which is good for the heart, which is MRA, ACE inhibitors, ARB, sacubitril, and so on, all increase potassium. In Mauritius, we just use very nasty to take. It was a severe constipation, it was perforation of the bowel. So we've got the new guys for platyroma and sodium zirconium cyclosilicate. The second one is critically fast-acting, very useful in the acute center, but very, very, very expensive. And for us nephrologists, as I said, we obsess about venuria, but also the rate of GFR decline. And we know that for people with diabetes, most of our patients are diabetic. With no treatment, they lose renal function at a rate of 12 per minute. If we control the diabetes, it gets a bit better at 8 per minute. We introduce ACE inhibitors, it goes down to about 6, and then we introduce a SGLT2, it's -2. So the question is, we keep adding lots of fancy new drugs, what's going to happen? This guy is published one of the papers I showed earlier, and he's just tweeted that yesterday or the day before, and basically trying looking at the various heart failure drugs, and comparing with the absolute risk reduction. Basically, the higher up, the better. And what is clear is that some of the new cardiac drugs, like the Vericiguat, I don't know anything about it, or Omecamtiv, has been a big disappointment. And we all know about SGLT2 doing very well. If you look at Paradigm, it's in the same level of benefit in terms of heart failure, but there are all long-established drugs like the spironolactone and ACE inhibitors as well, and Copernicus is carvedilol, are very well established and with good effects, good outcomes in heart failure. The interesting thing about, sorry, I keep going back to SGLT2 meters, but dapagliflozin, there was this subsection about people who are already on sacubitril valsartan and compared to people who are not taking it. And the interesting thing is, in both groups, there was similar improvement with dapagliflozin. It is interesting because SGLT2 inhibitors reduce hyperfiltration in the kidney because afferent vasoconstriction, whereas sacubitril causes vasodilation. And I think we need to look at it more closely. Maybe they are an ideal pairing to protect the kidney and the heart, or maybe they're not such a good idea. So we need to watch the space. I think this just reminds us of various drugs we've had: eplerenone, ivabradine, enalapril, dapagliflozin, all have very nice reduction in heart outcomes. So the 5 pillars of treatment of heart failure, these there, and you can see that most of them act on the kidney. Actually, even beta blockers act on the kidney, but of course there's more on the heart and the vascular system. So the heart and the kidney really work together, and I know we are hungry, food is coming. I think this is a topic for the future because the microbiome is very important both for the kidneys and the heart, so that's a potential future topic. So thank you very much. Any questions? Is everybody hungry? Okay, thank you very much.